they have to have some like definitive proof that this is causative. Most of the smaller glands, as you know, have irritative dominant symptoms, not obstructive. Interestingly, irritative symptoms respond very well to PAE,
Yes,
probably because
true.
of denervation. But overall, I would say that's why we don't limit it. I'd say I find smaller glands, ironically, a little bit easier because the vessels tend to be straight and not redundant. But our biggest challenge tends to be that first hypogastric run. That first run has to be with dense contrast because you're right, the arteries are so small.
Yes.
John, you pulled back here. It looks like there might be some other branches, huh?
Yeah, so I pulled back because I just didn't love the appearance. Okay, the prostate's 51 grams in size, but
51
honestly,
grams.
on that last run, I didn't see a whole lot of, there were any really gland staining, kind of above the margin of the symphysis. So I wanted to do
Play us that run because all we see is a black screen right now. So maybe play us a run.
Yeah.
And we're going to hop off in about 30 seconds to see Rob real quick before.
Yep. So here's the run
sessions.
more proximal, and there's I still think it's.
So here,
branch
what's
that-
interesting. Okay, so pause this. Just pause this. So now the obturator is the big one going left, but you have 3 branches off where you were, right? You were probably in either the bottom one or the top one, but there's a middle one, right?
Yeah, I was in the top one.
Okay, what do you think about, this is one of the few times I like an AP. If you're still here, do you mind just doing a quick AP run for me right here?
Of course.
Because in a type 3, it's one of the only times I find AP helpful. Because I think you'll be able to see what does bladder, what does rectum, what does prostate. So let's just humor me here real quick and see if this works. Yeah.
So
okay.
till you take the run, I want to ask you something. When do you believe, or what is the volume of particles per prostate, per side, that you would say that we have seen a very good staining, so we are dead sure that that the first one was very good, it was excellent. But sometimes you don't see the staining, you don't need to see them. Is there a volume that you would say that this is a premature embolization and actually it clogged very proximally? And if you see that nothing is going inside, you are frustrated and you feel that this patient will have recurrence?
I think it's difficult to predict an exact volume because in the beginning, everyone tried to say, 0.1 per, or maybe 1 cc per 10, 10 mLs of gland size, something like this. The problem with these ratios, and they were often with Embosphere, is that you can't see the beads. So oftentimes, even when you think you have a good mix, you just don't have a good mix. And the second challenge is it depends on the strength at which you're injecting. Like you mentioned, distal penetration in the gland is the most important thing. So I find that you can get very good distal penetration if your catheter is distal, and you may actually use less beads than if you're very proximal and you just are trying to get beads. So I don't know what your
I have
thoughts
something
are.
that it might look a little bit aggressive, but I always tell my juniors if they are doing PAE, sometimes when you inject, you find a very little bit of the particles refluxing. So you keep on doing it very slowly, and actually this is not the right thing to do because when the published series, when it was done with Lumi and we could see the particles were everywhere with very experienced. So I'm sure if we can see the particles with all my cases, particles will be literally everywhere. So it's a very safe procedure. Don't be afraid of doing
To push a little bit harder.
Of pushing harder, because reaching more distal is more important than because if you do, sometimes you do it like very slowly, and when you have the run, it's totally embolized.
Yeah.
And usually the center, when you do a com beam, the center is yes.
You got it. And, we all completely agree. John, by the way, of the 3 arteries, it looks like you found the right one.
Yeah, so now, having pulled back more proximal.
Yeah, it looks like you got into that bigger branch going down, which now gives you glandular staining, and
that's
you were
much
probably
better
in that
glandular.
second one, correct?
Correct.
All right, awesome. We're going to let you go because our session's wrapping up. I just want to check on Rob real quick in Georgia if we can, and just make sure. Hey, Rob, can you show us your hypo run real quick? While you're pulling up the hypo run, I want to reiterate what the other guys in the panel said about pressure of beads. They just reiterated that while injecting the beads, you can't be afraid to sometimes inject a little bit harder, which is key. But the only time I'd caution against that is when your catheter is very distal, like in the gland, then you can go through the collaterals. But, so it looks like here you're trying to get into this type 4 or low type 2, or is that coming off the obturator? What do you think?
I kind of got fooled. I think I fell for it. You know, I thought it was off the operator, so I checked that first.
Not
Didn't
off
see
the
it.
obturator, right?
So I'm thinking it's either a 1 or a 4, but I didn't. You know, I should have done a pullback retrospectively.
Yeah, so where are you right now? Do you have a pudendal run yet or no?
I don't have a pudendal run yet. I had snagged something here. No.
It looks like it could be promising. Where's that going? But that could also be a capsular, right? Anything coming off the pudendal could always be a capsular, but if that microcatheter is not going, it's probably a small vessel.
Yeah, I'm gonna not force it. It doesn't want to go.
Why don't you bring your microcatheter a little higher and fish from higher? Because if you're catching something small at the pudendal, my rule of thumb is it's probably the capsule. Yeah. And then you could, I know you want to limit contrast because of CKD, but you could always do one pudendal run there in a contra, and if there's a vessel coming off the anterior wall, that's your vessel.
So I have a question.
True.
And there's a question for you too,
No,
coming.
it's like for all you guys. If you don't choose Conbeam, what do you do sometime if you don't find any prostatic artery? You go to the femoral artery
Yeah.
and you look at it, and what confident you'll be.
So if I don't see on my hypo run, let's say I don't see a good filling prostatic artery, and there is an obturator, like it's anatomically present, I'll select the umbilical artery, do a pull out of a type 1, do a proximal obturator run, and a proximal pudendal run. The gluteal incidence is like 1 in 1,500. So, but I typically will have to have seen it. If I don't see the obturator, I still would do those 2 selective runs with a microcatheter, and then I'd go check the external. How about you? Yeah.
Yeah, well, it's easy for us because we do Conbeam
Yeah.
all the time. So if we don't see it, we do a proximal run in the common iliac and look at what will be the arteries that's going into the prostate.
Are there times you guys don't see it with cone beam, though, because of vascular disease or just poor filling or poor timing, that you just have to do the run anyways?
I didn't have this problem. We had this problem, especially if you have a replaced prostatic artery.
Yeah.
It's the main problem. But if it's occluded, we still see enhancement. What can be done also is delayed Conbeam with like an arterial and the delayed phase, and you will still see the enhancement and see if there's occlusion and some collaterals. But I've never faced a case of never seeing a prostatic artery raising, and if I search for it, it's from a replaced prostatic artery.
Yeah. I had once the prostatic was totally occluded for some reason, maybe a plaque or something, and then I did cone beam, but the whole prostate was supplied by the middle rectal, and it was supplying the rectum, and it was like the anal canal doing like this, and then the prostate coming out of it. I wouldn't have suspected this without the cone beam, but I'm not sure what to do. I have so many unlucky cases, but in the end they were done, so it's up then I was so frustrated, but afterwards it turned out to be amazing. So
Yeah, oftentimes I'll go to the other side if I don't see something, and like this, it'll be fed
and
from the other
sometimes
side.
you go to the other side and you find the whole gland supplied by one.
Exactly.
That's why, but very frustrating when you don't find from the left, and then you go to the right, and it's still very difficult.
I have another question. Do you do any pre-embolization imaging like
CTAs,
CTA
MRAs.
or MRA?
We don't do any of them. I'm a believer in not exposing them to radiation either, which is why we like using, C-arms. I mean, all the imaging you guys have been seeing is on portable, mobile C-arms. And actually that dose is in the lower left. It's 250 milligray, and he's already done the left. Rob, by the way, there's your artery, right? So do me a favor here. Just go to a contra and do the same run. And the vessel will be 4 centimeters proximal to you, and it'll be easy to see. And this is a good example of when to do a contra. So the wire
You want to keep
wouldn't...
the catheter there?
Yeah, just stay where you are because you know you fill it on a reflux. Do the same strength injection in a contra and you'll see it.
Okay.
It'll cost you 2 cc's of contrast. And probably 5 milligray, that's it. And you'll get your...
I'll tell you something about the pre. I had this discussion with Tiago. We did lots of workshops here in Egypt. And he's actually a guru in reading CTAs. He's like, I once sent him one who's very important. He was not in Egypt. And he just drew it like, and when we did the angiogram, it was exactly the same. But the argument here is, for me, in like 1,400 cases, if I did a CTA for all the patients, how many patients would I say, no, I'm not doing this? Maybe
my
3 or
God.
4.
Yeah,
Maybe 3 or 4. So it's
I totally agree with you. Sometimes CTA will make it's more scary than
Yes.
it is really. We have done like patient with stent graft and like stent graft is branched into the internal iliac. It always goes quite smoothly. But one of the question is, especially patient with atherosclerosis, what we find that I love to have them in MR because sometimes we have like a left gland very big and the right gland is very small. Sometimes they have very asymmetric glands. And so for this, I find that in very elderly patients, it's quite easy. I go always for the larger gland and leave the other one. That's why I prefer to have them at least an MR.
Yeah, and a
Not
lot of
an
our
MRA.
patients, I'm sure it's very similar both in Europe and Middle East, is that we will get MRIs anyways because they have an abnormal PSA or either prostate velocity or PSA density, and so they will, or fraction, so they'll...
So since you mentioned the PSA, do you depend more on the prostatic density? I mean, for me, I hate to do a 60 cc prostate with a 7 PSA total. I'm not talking about cancer. I'm not. Than to do a 200 cc prostate with 12 PSA. For me, the lower the PSA in relativity or relatively to the prostate size, the better.
Yeah. So the numbers we use are a prostate fraction of 10%. Yes. So if it's less than 10%, the incidence of concomitant prostate cancer is less than 2%. So that's a pretty safe number to use. So actually the examples you gave, 200 gram prostate and a PSA at 12 and you're roughly 5-6%.
No, this is totally okay. I'm not, this is
It's a
the free
great
over
number to
total.
know.
I mean the prostate density when the prostate is very dense.
Yeah. Oh, dense tissue. Yeah.
Yes, dense tissue. So if we say that it is 10 for 100 cc, if the free over total is over 0.25, 0.3, 0.33, this is not cancer because PSA is prostate specific, not cancer specific. But the very dense prostate that wants to go out of the capsule and not going out. So if we are having like 100 cc prostate with 10 PSA, if you have 100 cc prostate with 6 PSA, this would definitely do better with embolization than with the 10 because the density is less.
Yeah, no, I agree. You have more glandular tissue in those situations. Hey, Rob, just show us your run. I think you made it clear. We're going to probably sign off from the live stream.
Yeah.
But I just want to show everybody the contra just before you leave. So here are your catheters in the pudendal artery. It's going down the middle, and you're refluxing back the artery that's going screen left. That's the prostatic, right?
Correct, yeah.
Great. Put it on native for us, non-subtracted. So there it's really clear, right? And you could see why it wasn't catching before because everything was probably going down the artery on the right, which is the gluteal. So this contralateral is just so valuable in this situation. Yeah. We'll let you work on this. We're going to sign off because our session's over.
One last question
But he's
because
got
we will
one
have
last
to
question.
wrap up. Yeah, for you. We have seen so many amazing operators. How do you train the people in our centers? Walk me through the process of new one training.
So
because I think these are private patients, right? So
training for us is pretty rigorous. So we'll do a series of different didactics. They'll get a shared folder of 20, 25 key prostate articles and data that you should know. Small beads versus large beads, presence of cancer, PAE PAE for LUTS in prostate cancer patients, PAE for retention, PAE for hematuria. So you have all the medical background. Then they will spend a few days of just case observation. Well, they'll see about 10 cases in a couple days. and then go through a checklist. So it's anatomy, patient workup, collateral management, but all in the lab, watching and learning. One, the equipment, which I think is very underrated in PA, knowing how to use the equipment very well. But some of the simple things, which is, like, I mean, you guys mentioned it earlier, how hard do you do your injection? How do you mix your beads? How do you get the pictures to look like this so they look good with by hand? So we'll do that for about 2 weeks. After 2 weeks, they'll usually go through about 40 cases live, like hands-on cases. Then we have this live stream system. So all of our 45 plus labs in the United States, they're all hooked up on one live stream. If you need help, they're there. We're all on one PAC system. We do case reviews. So I think the mentoring program is very intense in the beginning, but then it continues monthly M&M, interesting case conferences, and just keep showing, and sharing case. It's constant sharing of, because even like I was telling you the other day, I did a case in California and I couldn't find the prostatic artery. I did 7 different runs and I said, I can't find the artery. And I've done thousands of these cases and I'm like, where is this thing? And, there was almost no answer. I got to call one of my colleagues and say, hey, can you look at this case and see what you think?
It happened to me very recent, and it was with people who never saw me doing it before, and I was supposedly the expert, and your first case in front of them, where is the prosthetic artery?
Yeah.
Let's see, let's go out a little bit, let's go in, let's do cone beam, and we can, nothing.
Yeah, so it happens in everybody, and it's great when you're constantly sharing and doing that. Rob, good job getting in that artery. We see in that middle screen for us you got in. So
Thank you.
we'll let all you guys go. Thank you all, Ivy, John, Ari, Mike. I know Don and Steele, you had a little technical difficulties in Austin, but we appreciate all of you guys getting on live from there.
Thank you, guys. Really, great job. Thank you.
Thank you all. Thank you, Mr. Dr. Sandeep, Dr. Sham, Dr. Karim, for our very intelligent and very complicated cases. And thank you, the audience. And we have finished this. Thank
Grab a drink with Dave.